You're listening to Civic from the San Francisco Public Press. Drug overdoses have killed more people in San Francisco than COVID has in 2 years of the pandemic.
We've seen overdoses in our office, in front of our office. I live on Leavenworth, and up and down that street, it's constant overdoses when people just drive by.
This is widely recognized as a crisis, and it's often pinned on the arrival of an incredibly potent opioid called fentanyl. But the problem of overdoses is more complex than that.
The drug itself, fentanyl, has not necessarily changed since 2015, but the conditions under which people are using have changed.
Today we'll take a close look at the different parts of this crisis and how we got here. I'm Laura Wennis, and this is Civic. Before we start the show today, a few things. First, if you caught last week's show, you know that I actually no longer work at the San Francisco Public Press and have left my position as host of this show. These interviews were recorded before my departure. I just wanted to make sure that they get out there, even if I'm no longer around. Second, a word of warning. These are heavy topics we're getting into today. We'll, of course, be talking about drug use, but also about death. There's mention of sexual assault and other traumatic events. Please take care.
Some sad news there tonight. The city is on pace to surpass last year's historic high of drug-related deaths. Medical Examiner's Office released a new data today. Report shows that fatal drug overdoses in the first 2 months of this year are up 69% over last year.
The number of fentanyl overdoses continuing to surge around the Bay Area and across the nation.
San Francisco police say 3 people were found dead in the Mission District early this morning. Police say they have reason to believe the people may have suffered a drug overdose.
Overdoses are a crisis in San Francisco and beyond. The numbers are bleak here. 711 people in 2020 and 645 in 2021 suffered fatal overdoses. These are horrific figures even without counting all the non-fatal overdoses and other suffering associated with this crisis. The city, recognizing this, decided to declare a state of emergency about drug use and other issues.
The Tenderloin needs an emergency response, period. Just imagine if you had to walk your kids down the streets of the Tenderloin every single day with people shooting up, selling drugs, and because the sidewalks were so packed with people, you had to walk out onto the street in incoming traffic on a regular basis. We are not giving people choice anymore. We are not going to just walk by and let someone use in broad daylight on the streets and not give them the choice between going to the location we have identified them or going to jail.
There's no shortage of urgency in the conversation about addressing this crisis. Despite that, I wanted to take a step back from the immediate actions and try to get a better understanding of the roots of this. Why were there so many overdoses in the city in recent years? What are some of the policies and interventions that are already in place, and do they work? How did we get here? I talked with about 7 different people about this to try and get a deeper understanding of what's happening. In this first of 2 shows, I'll let them outline what they're seeing. First, this is a nationwide crisis, and it's not new either. Dr. Hillary Cunnins is the Director of Behavioral Health in San Francisco. This is very much in her purview.
I am a physician, and specifically both a primary care and addiction medicine physician, having worked in clinical practice for many, many years in New York City and specifically the Bronx, and transitioned to work in public health first in New York City and now here in San Francisco. In my view, the drug overdose deaths are in fact a crisis. They are epidemic. We saw in San Francisco a very steep rise in deaths due to overdose starting really late 2018, really emerged in 2019, and in 2020, more than 700 San Franciscans lost their life to overdose. We did see a decrease in the preliminary data from the medical examiner report that is available publicly. We saw a reduction to about mid-600s. Still very high and still significantly higher than where we were at before in the mid-20 teens. And I think it is, on the one hand, because of stigma, because of, I think, misunderstandings about the disease of addiction, about misunderstandings about the determinants that might lead a person to use a substance and then develop an addiction. I think that we, for a long time, haven't always done all the things that we know could be effective as a country. This is really not San Francisco specific. And what has happened in the last few years across the country, including in San Francisco, is a willingness to expand the approaches that we know to be effective scientifically, try new and innovative approaches that have the potential to be effective, and continuing to invest in and really ask all of us, community members, health professionals, government, to take every step we can to change the trajectory of this epidemic. What we are increasingly, I think, facing both here in San Francisco and nationally is the extent to which addiction and substance use really has underpinnings around a lot of this, what we call social determinants of health, particularly around income inequality, inaccessible access to living wages, discrimination, racial and otherwise, resulting trauma from racism, from other kinds of life experiences, and addressing, in addition, the sort of medical and biomedical and sort of the harm reduction approaches that I'm describing. Taking really a broad and multi-pronged approach is really important here, addressing sort of the underpinning social factors that also create the conditions for this epidemic is vital and really requires, in my view, a whole of government response, working with our partners in social services, working with our partners on the public safety side, and importantly, working on issues around housing and access to housing, which of course is happening here and is top of agenda in San Francisco. So all of this together is really where I think we need to go.
I talked with Dr. Dan Ciccarone, a clinician and a professor at UCSF's Department of Family and Community Medicine. He researches the public health aspects of drug use. That research has taken him out into the field a lot, observing people who use drugs, trying to understand how and why they do. You've described the situation with opioids as a triple wave epidemic, and then in 2021, you also described what we're currently experiencing as a fourth wave. What are the waves here?
So I coined the term triple wave, which is now of wide use, to give a nice metaphor to the waves of overdose that have happened over the last 20 years in regards to the opioid class of chemicals. The first wave are overdoses due to opioid pills that peaked around 2010. And as we became aware of that wave, we started a number of programs, for example, prescription drug monitoring programs, guidelines on prescribing opioid pills. That brought that wave to come down slightly. But unfortunately, there was an intertwining and intersection with street use of heroin, where people, often patients, migrated from medical care with opioid prescriptions to street-based pills and heroin. And that led to wave 2, which was a heroin overdose wave. It started picking up steam around 2011, peaked around 2014. And then a very unfortunate and very deadly wave where heroin became adulterated, contaminated with, poisoned with synthetic opioids such as fentanyl. That wave is still with us. It's still growing. There were 70,000 Americans have died from synthetic opioids, including fentanyl, in the last 12 months of data that we have. That's the triple wave epidemic. And then the fourth wave is stimulants, which include cocaine and methamphetamine, which are coming in very recently in the last year or two. People are using them both independently, but also in combination with heroin and fentanyl. And because the methamphetamine is of historically high potency and purity, and it's being combined with a very potent opioid such as fentanyl, that's leading to a fourth wave of overdose mortality on top of the triple wave.
I heard this over and over again in my conversations. Fentanyl is a big deal, but it's not just fentanyl that's driving this. Let's break that down, starting with a clear understanding of what fentanyl actually is.
So I've explored fentanyl both from interviewing folks that use it, but also diving a lot into the epidemiology, diving in a lot into government documents, such as those from the Drug Enforcement Administration, about where fentanyl is coming from. So what fentanyl is a synthetic opioid. That means it's not derived from a natural product. It's not derived from the poppy plant. It's created in a pharmaceutical lab. It's a very potent opioid. We use it successfully in surgery and anesthesia. We even use it in childbirth. We like it because it's potent, so you can take someone who's in severe pain out of severe pain. We like it because it's quick acting. We also like it because it's short acting. So imagine that you're in the childbirth setting where you use this powerful opioid. You want it to wear off quickly, so you have control over it, and the mom and the baby can be kept safe. Now, the fentanyl that we're talking about now, which is super potent, it's about 100 times as potent as morphine, a classic pain relieving medication. It's about 40 times as potent as heroin, which we already understand is a very potent opioid. And because of this potency, and because the fentanyl that's on U.S. streets right now is illicitly manufactured, we don't know what level of purity it is, we don't know how good it is, we don't know how bad it is, that makes it a very dangerous chemical. Heroin in and of itself was already uneven with vicissitudes in purity and potency, made it dangerous. Fentanyl just magnifies the danger. And then in addition, if I may, fentanyl is a subclass of the opioids, and it has a lot of chemical cousins, if you will. We call them analogs. There are dozens of analogs out there right now on American streets. All these products are illicitly manufactured. We're not talking about diverted pharmaceutical products. And the problem with these analogs, these dozens of analogs that are out there, is that each one has a different potency than the other one. So you could go from fentanyl, which is 40 times as powerful as heroin, to a milder fentanyl analog, say butyrofentanyl, which is 3 to 4 times as potent as heroin, and then back to mother chemical fentanyl. And that shift in potency creates a very dangerous risk environment as well for the daily heroin/fentanyl user.
This may not be your purview. This may be more of a law enforcement question, but just in case you do know, do we know where these literally come from? Like what part of the globe? Are they manufactured illicitly in the U.S.? Are they illicitly imported? Like what's happening here?
Yeah, so my interpretation of that comes from the U.S. Drug Enforcement Administration and also the High Intensity Drug Trafficking Group, the so-called HIDTA law enforcement group. They get data from Customs and Border Patrol. They get data from other sources of drug flows into the United States. And what they're saying is that most of the fentanyl that has come into the United States since the third wave of the triple wave, which is about 2014, began, it's illicitly manufactured. The main source, initial source of production is China. And then it's shipped into the United States in 3 ways. One is there's a big flow to Mexico, where the criminal trafficking organizations in Mexico will then co-ship it with the heroin or even pre-mix it with heroin, then ship that product across the U.S.-Mexico border. The third one is direct importation. Think about sort of the dark web, where people are buying fentanyls from illicit producers and sellers. These, again, stem from China. The third route, which is becoming increasingly relevant and worrisome, is shipping through Canada, where some of the fentanyl is being pressed into counterfeit pills, and those counterfeit pills then come south through the Canadian-U.S. border.
It's worth keeping in mind that fentanyl isn't new. It's been on Tracy Helton Mitchell's radar since about 2014. She's an addiction specialist and a person in recovery. She's also the author of several books, including The Big Fix, Hope After Heroin.
Around 2014-ish, I knew people who were purchasing fentanyl through the darknet markets and having it sent from places overseas. And then quickly it started to get into the markets on the East Coast, and then eventually it came out to the West Coast. We were sort of one of the last places to get it because typically on the West Coast we have what's called tar heroin. But now you can purchase fentanyl by itself, and then that's where you see people smoking it off the foil. But it came in because it's much, much cheaper. You can produce it for much cheaper. You don't have to worry about growing conditions of the poppy. You can make it in a lab, and supposedly the profits from it are much, much higher. And it's so potent, it's just a small amount that you can bring and add a bunch of additives and stuff like that if you're selling on the markets compared to, all the different mechanisms that you have to use preparing opium poppies.
Why are we seeing so many overdoses involving fentanyl?
Because it's so potent. When I had my first child, they gave me fentanyl in the hospital for my C-section, some of the pain involved in having my C-section. I've had fentanyl for another medical procedure. I mean, it has a medical use. That being said, you don't have people measuring it out in this, the drug markets. Let's just say you buy a bag of powder. You don't know, is the fentanyl in the corner? Is that the amount that you're getting? And there's all these other cuts that's in it. Are you getting the most amount of fentanyl? Like, how much fentanyl is actually in it? And what is the concentration in it? And no one knows. So it's a gamble every single time because you have such a potent drug.
Which brings us to another major factor in this overdose crisis. It's not just fentanyl. A lot of overdoses happen when people take multiple different drugs, and they're by no means exclusively opioids. Sometimes people don't know they're using fentanyl. In mid-March, San Francisco's health department sent out a press release noting that 3 people had suffered a fatal fentanyl overdose and 9 people suffered non-fatal fentanyl overdoses who reportedly had intended to only use cocaine. The release went on to note that here, fentanyl is often sold as a white or lavender-colored powder and might look similar to cocaine. But people who use stimulants may have little or no tolerance to opioids, which is one reason fentanyl overdoses very frequently involve cocaine and or meth.
So when people think of overdose, they tend to only think of opioid overdoses. But I mean, there's multiple kinds of overdoses. So in San Francisco, we definitely get our share of stimulant overdoses, which present differently, where potentially a person can have elevated blood pressure. They could have a blood clot break off to their brain. They could have, a lot of different things happen, ending up in a stroke or heart attack or various medical issues that are related to stimulants. Then there's an opioid overdose, which typically involves a depression of the central nervous system, where then their breathing shuts down and then the oxygen levels shut down their brain. I'm not the medical expert on that. I just know what I've seen working and seen in real life, like in my personal experiences. I've seen both stimulant overdoses and opioid overdoses. And then you can have overdoses on other types of medications like benzodiazepines. I've seen those, many times. It's another central nervous system depressant. So there's lots of different types of overdoses. And also what we see a lot in San Francisco is, people using multiple substances at the same time. So it can be, I'm taking speed, then I need to go to sleep. So I'm using an opioid. So then I'm having, all these different things. I haven't slept in a few days. So my health already isn't good. I've been outside, living outside homeless, and my health isn't good. My systems are getting overloaded by all these different drugs at one time. So the presentation isn't always the same from one circumstance to the other, and it can depend what drugs that you have in your system at that time.
Does it usually involve somebody not knowing how much or what exactly they're ingesting or taking?
When I used to use drugs, I'll make it in the first person. When I used to use drugs, I'm buying something and I don't always know what the potency of it is. So I know I was buying heroin, but I don't know what the potency of it is going to be today because I'm buying it in the street market. So if today is 40-something% and yesterday it was 20-something%, I can have an accidental overdose just because I'm not used to this particular potency. So even if people are buying fentanyl, which is the main driver of overdose right now, they don't know necessarily what the potency is. So there are people who are buying cocaine that's, somehow been cross-contaminated with fentanyl, and then they are having an accidental overdose. There are various types of accidental overdose. It isn't just one particular thing.
Some organizations that work to prevent overdoses specifically use language that doesn't pin this overdose crisis on opioids alone. This is Eliza Wheeler, director of the Remedy Alliance for the People, which works to ensure that harm reduction programs across the country have access to the overdose reversal drug naloxone. Your organization, as I understand it, objects to the term opioid epidemic. Why is that, and how should we think of what's happening across the country and in San Francisco that's leading to so many overdose deaths?
Well, the term opioid crisis or opioid epidemic puts the focus on the drug itself and detracts from the fact that this is not about the drug itself. Opioids are a incredibly useful and crucial essential medicine. And there's been a lot of objection to the term opioid crisis among harm reductionists and folks working on drug policy work, and really wanting to shift the focus to overdose crisis and supply crisis, and kind of thinking about the way in which drug policy and prohibition have in fact created the overdose crisis, not the drug opioid itself.
I see. Is there also an aspect here of that particular focus of like, oh, it's opioids that are so terrible, or like, I've talked a lot in this series about fentanyl and the dangers of fentanyl. Is there a problem there too with leaving out other substances that people might be using at the same time and how those lead to overdoses?
Sure. There are many drugs that can be involved in a polysubstance overdose. The focus on fentanyl in particular is understandable, considering the rise in fentanyl-related overdoses or overdoses that involve illicitly manufactured fentanyl that is on the street now. But yeah, definitely focusing solely on opioids does distract from the overall impact of extremely poor drug policy that this country continues to invest in. Fentanyl overdoses have risen all over the country at various times since 2013 or so, when fentanyl overdoses first started upticking on the East Coast and in New England. And, we've had fentanyl here in the drug supply in San Francisco since at least 2015 in a large quantity. It's always been around here and there, but really started to begin saturating the market in 2015. And COVID exacerbated pre-existing conditions that contribute to overdose risk, wealth inequality, folks being unhoused, having lack of access to resources, the impact of, law enforcement and city crackdowns on folks who are unhoused, separating groups that were taking care of one another, people being isolated. You see the huge spike right around the time that the pandemic began, and the drug itself, fentanyl, has not necessarily changed since 2015, but the conditions under which people are using have changed. Fentanyl is a powerful opioid. There's less room for error. If there's even a slight change in the strength or dosage, then it can possibly result in an overdose. But focusing solely on the drug itself, again, is a distraction from all of the many factors that are contributing to people's risk. I think that the hysteria around fentanyl is in many ways unhelpful and causing harm. We're seeing this perpetuated myth that law enforcement can overdose from touching fentanyl and being around fentanyl, which is absurd. And yet we see it continuously resurface in the media, and we see this happening all over the country. They just, a 13-year-old person overdosed in a school in Connecticut, and they shut down the whole school and decontaminated it with inexplicably OxyClean. What? This was in the news. It's wild. And what this does is people kind of laugh it off like, oh, it's just law enforcement being hysterical and being ridiculous and perpetuating misinformation. But it's actually resulting in an escalation of war on drugs and prohibitionist policies. There's legislation being introduced in West Virginia right now that criminalizes people who use drugs for exposing, quote unquote, law enforcement to fentanyl.
Whoa.
So these are the ways in which misinformation and hysteria actually directly translate into harmful policies that further criminalize people who are using drugs in a way that does nothing but results in their incarceration. And we have long seen how the war on drugs has impacted communities of color, people experiencing poverty and homelessness. So kind of using fentanyl and the rising death toll to justify a double down on policies that actually do nothing to solve the problem and harm people is not the direction. We need to do some creative strategizing around access to services, around access to non-coercive, low-threshold drug treatment that people want, that works for them.
Here's Dr. Dan Ciccarone from UCSF again on the topic of polysubstance overdose.
Fentanyl is still driving overdose deaths, both by folks that are using it by itself, because now there's a small but growing subset of the population that's not using contaminated heroin. It's using fentanyl all by itself, knowingly and maybe even with preference. The second is there's still a lot of heroin contaminated with fentanyl, particularly in the zone of the country that it started in, which is the upper Midwest down to Appalachia, the New England states down to the mid-Atlantic states. That area is still getting heroin that is largely adulterated with or substituted by fentanyl. The third is that there are people who are combining it, or there might even be some of these stimulant products which are in a low-level way kind of being contaminated with fentanyl. And the important thing to remember there is that stimulant use in and of itself often isn't deadly, particularly not to young people. Maybe to the older person who has some vulnerability, perhaps in the heart, perhaps something that might cause a heart attack or an arrhythmia that could lead to death. But in young people, stimulants tend to be well tolerated. The fact that we're seeing rising mortality from methamphetamine tells me that there's something else going on. And that something else is the combination with the fentanyl. So at least half of methamphetamine deaths, for example, nationwide, at least half are co-occurring with fentanyls. And so to answer yes to your question, yes, we need to focus on fentanyl. To answer no to the question would honor the idea, and we've known this for a long time, that people often don't use substances by themselves. And so to say we're over-focused on fentanyl is to honor the idea that polysubstance use has always been a phenomenon, and we're back to that truth again.
People may also use more than one substance as a survival or defensive strategy. This is Tracy Helton Mitchell again.
I mean, for me, being a woman, being homeless, I used meth to stay awake so people didn't rape me when I was asleep.
Yeah.
I mean, that's straight up. Like, mostly I was an opioid user, heroin particularly, but I would use meth to stay awake because I would stay awake and then I would sleep during the day, but I wanted to have my wits about me at night because I didn't want anything to happen to me.
Yep.
And then it's hard when you're sleeping during the day, to go to your appointments and stuff like that. So it ends up being this whole cycle of like not being able to get anything accomplished.
There's also the question of where to go to use drugs. The rise in overdoses has coincided with a time of increased vulnerability for some people who use drugs, and an increase in difficulty for some homeless people who are looking for shelter. Communal shelters closed for a time, then operated at limited capacity. The city put some people in shelter-in-place hotels, but prioritized the most medically vulnerable. And that program is ending too.
I was homeless and I was using drugs outside. Would I have gone to a consumption facility? I probably would have. It's extremely embarrassing to be using drugs outside, and unsafe and unsanitary. I had 34 abscesses from using drugs outside. In the early parts of my drug using career, people would let you use the bathroom and go inside, and they didn't care necessarily if you used drugs as long as you were clean and you didn't leave the bathroom a mess and you bought something. I mean, now there's no bathrooms to even use in San Francisco if you have to find a bathroom to use. There's no place to go. I mean, when I came to San Francisco, you could get an apartment for $450 a month. 2 people on general assistance, which people typically think of as welfare. Now they don't even call it general assistance, could put together their money and get an apartment. And one person would sleep in the closet and one person would sleep in the inside part of the studio or whatever. And you could get a hotel room for $25 a night. And the city gave away hotel rooms. And there was places to sleep. And if worse came to worse, people would break into a lot of the buildings that were abandoned after the earthquake. There was a lot of empty spaces. There was places that you could go. People don't want to use drugs outside. It's just the only place they have to go.
Just to be clear, that's not to say that every person who suffers a fatal overdose is homeless, or that all homeless people are necessarily using meth, fentanyl, or other drugs. I talked to one person who's worked on several of these related but distinct issues. Her name is Laura Guzman, and she's the Senior Director of Capacity Building and Community Mobilization for the National Harm Reduction Coalition. you talk about the link between housing, and I'm thinking here particularly of homelessness, and drug use? Because I think there's a tendency to conflate them and for people to think, oh, homelessness and drug use, they're one and the same, or they overlap so much that we have to talk about them as one thing. Are they?
This is a very, very important question because I worked in homelessness and housing for almost 2 decades. And actually, even in the last 3 years before joining the Hammer Action Coalition, I was in Alameda County. I actually led the homeless count in 2019. And it's very important to first understand that we have been doing point-in-time count surveys for people who are unhoused. And in the last 10 or 15 years, when we survey people, what they tell us themselves is that the percentage of people that have actually been impacted by drug use and became homeless is about 30 to 35%. So we know that there is a subset of people who, due to what we call chaotic drug use, may have become homeless. But the majority of people who have gotten chaotic relationships or coping relationships with drugs have been as a result of their homelessness. And yet, having served at a drop-in center for 16 years, I could tell you that a good majority of people not always use drugs. They were not regular drug users or impacted by drug use. They were just simply poor people who don't have enough income to pay for housing. So it's very important that we separate those two items, but also to know that we just, through our California Hammer Action Initiative, have been surveying participants of syringe exchange programs on the ground. And this is our second iteration, was done in October. And we have used the federal definition of homelessness and discovered that of people who are using syringe service programs, 75% meet the literally homeless definition. And in some ways, what this actually unveils is the fact that housing is not accessible to the majority of unhoused people, but it particularly targets people who use drugs because of stigma, because of barriers that come from, the way that landlords may manage their properties and exclude people with histories of substance use, and the fact that both nonprofit housing and for-profit housing may also easily evict someone for their use of drugs. So we always see homelessness actually not as a result of drug users and homeless people equated, but rather that homelessness is also perpetuated towards people who use drugs because of, again, stigma and policies that are built not to actually allow them to access and retain housing.
She also says that, as in so many other areas, COVID has really intensified existing disparities.
In particular, during the first COVID year in 2020, we have been talking a lot about the drug overdose rates, but there has been a staggering increase of 50 and 43% increases on death rates for Black and Indigenous Americans in California that have been actually researched. There is a recent paper that was put forward by folks in LA, researchers at UCLA, that show basically that the explosion of fentanyl, in addition to all the systemic violence that has been historically impacting Black and Indigenous communities, is showing that actually target of these new overdoses really is Black and Indigenous people. And I think that Latinx are following that trend. So in some ways, it's interesting to know that with health disparities, no matter where you see them, right? In this case, the increasing toxicity of the drug supply has really disproportionately affected communities of color. And I could tell you in San Francisco, for example, there were more deaths in 2020 of overdose among Latinx than there were from COVID, even though COVID really impacted our communities. And so the way that we look at this disparities is to understand that when you talk about drug use in general, there's still the way in which communities of color have been historically oppressed makes them much more vulnerable to be targeted with, for example, bad drug supplies or very unstable drug supplies. The fact that people need to recur to get medications, drugs to relieve whether it's physical pain or emotional pain on the street, because doctors will unlikely prescribe them to, in particular, and this is historical, to Black and Brown and Indigenous folks. And so what we're seeing is that right now, as we talk generally about an opioid crisis, this particular moment, the disproportionate impact is on people who have been already impacted by health disparities, by the lack of health access, culturally, linguistically competent, by the lack of access to both actually mental health and substance use treatment. So those things kind of get combined, and COVID was really pivotal to see how these numbers continue to be increased. So in San Francisco, the ratio of overdose-related death is 6-1 on Black folks over white folks, even though they're, 5% of the population of San Francisco.
This combination of problems is particularly visible in the Tenderloin, which has a reputation. Elgin Rose lives and works there. He's director of outreach for the nonprofit Code Tenderloin and saw some of the COVID safety measures backfire a bit. Joelle Yates is a case manager at Code Tenderloin. Both of them are in recovery, and neither of them is surprised that the Tenderloin is seeing such a huge number of overdoses. You'll hear Elgin first. Overdoses killed more people than COVID did in 2020, in San Francisco at least, and I believe that was true in 2021 as well. What does that number, that comparison, say to you both, if it says anything at all?
I'm not surprised. Just having that closed eye to what's going on in the neighborhood and for so long, and then, and expect results from not doing anything is what we knew was going to happen. We've seen overdoses in our office, in front of our office. I live on Leavenworth, and up and down that street, it's constant overdoses. So, and people just drive by. So I'm not surprised at all.
Yeah.
I'd say it says two things. It says there's a lot of work to be done, and it's a result as well of the work that was done to protect folks from COVID, because a lot of people were pushed into this neighborhood from other neighborhoods. And so you got a concentration of these cases, which would have been spread out amongst the city.
Can you say more about that? How people are pushed into this neighborhood that might have otherwise ended up, using drugs in a different part of town?
People may be concerned about their businesses. Tenderloin has been nicknamed, so it's like the cesspool of the city. So as far as patrolling for areas and protections that you'll have in other areas, more things are allowed here as far as tradition and as far as lack of care for this neighborhood, which in some circles is not considered a neighborhood at all, but just a throughaway just to get to other places.
And if I could add, COVID was a reason to start yelling when the problems was already here. So it was kind of like it was exploited, clearly and highly exploited, to address the homeless situation when COVID first hit. It was like, oh, this big thing going on, and all these people were doing bad, but people were doing bad prior to COVID. So COVID was almost was a way to misrepresent what was really going on down here. So it was like, oh, COVID, let's help these people. But prior to COVID, it was like, oh, let's keep driving.
Yeah. Did that work? I mean, did it work to point to COVID and say, like, well, now that we have a crisis, let's pay attention to all of these crises? Or did it just keep getting sidelined?
Not at all. Not at all. I think the crime in the city is a bigger headline that's just making this so atrocious now. I mean, they put folks in hotels and all these things, these cosmetic fixes, in the name of COVID, but didn't dare touch the person or address what was going on with that person individually. So I would say that COVID, I think, almost was a bigger distraction for the core problems in the neighborhood. People need help. It's like they sit outside my job, they sit outside where I live at on Leavenworth, and people are not happy, people are in pain, and it's out of hand. It's been drugs down here for a while. Like the declaration of an emergency, it's been an emergency. And that doesn't make it like it ain't one now. So we do want to scream to the top of the heavens that, this place needs some support. The overdoses shouldn't be at the level that they are on, and just the drug flow shouldn't be here. And so, until it's actually responded to as an emergency, the people are going to just constantly be in trouble. So bring the help.
Yep.
Yeah, it's just, I put it simply, it's a lot of people dying slowly. I never knew opiate, the addiction, or all what's concerning that arena of things firsthand until I moved to Tenderloin. Then the victims of it were my friends, or just people in the neighborhood, just see them fall apart over the years. When you really, you put a face to it, you don't forget it, If you don't believe the news, just come see it.
What kind of help have people brought, and what else could work? We'll get into that in part 2 of this series. We'll talk about how people who use drugs are reversing thousands of overdoses a year. We'll talk about harm reduction and how it's being applied. We'll talk about what treatment for opioid use disorder can mean, what recovery can mean, and how activists, volunteers, and the city are trying to help people find their way there.
The DOPE project last year had reversed an estimated 8,200 possible overdoses.
That's coming up soon. I'm Laura Wennis, and you've been listening to Civic. Civic is produced by KSFP-LP, a project of the San Francisco Public Press. Our team includes producer Liana Wilcox and contributor Mel Baker, who's also programming director for KSFP. Our theme music is by John Dillon. Thanks for listening.